Tearing versus an episiotomy. Tale as old as time, which one is better? And I'm here to tell you that what they told you when your mom had a baby is actually different than we think now. So be sure and watch this video because it can be really important as you head into your delivery. And I just want you guys to know that I'm coming from a person who's pushed with patients for 20 years at the bedside with thousands of patients, along with looking at the studies and the most current literature, as well as having practiced for such a long time that I've kind of seen perspectives change on this situation. So I'm really glad that you guys are here. In this video, we're going to explain the differences between the two, why they might cut versus let you tear, and how to talk to your doctor about this tricky subject, which, yes, I wrote up a whole article on my website, and I think the whole time inside I was like, because it's not a fun thing to talk about, but super important for you guys to know about and to know that there are studies about what they should be doing. First off, I want to go over some definitions, and I'm going to use my baby and my pelvis over here. Okay, so I don't have a crocheted birth canal, but for right now, this little symphysis pubis is going to act as your perineum, which is the area between the birth canal and your rectum anus area. That's where your poop comes out. Now, I think it's really important to know that 90% of people have some tear when the baby comes out. So that's a first degree, second degree tear. Doesn't mean it's a big tear, doesn't mean it's hard to recover from, but as you can imagine, that area is a little bit small for a baby to come out. So that area can rip a little bit, and they grade it on a scale of 1 to 4. So 1's just a little bit of tearing, 2 is a little bit more, 3 we're starting to get into the anus tissues. That's the area around your rectum. And then 4, we're getting closer into the anus where the musculature of the anus are involved. So we want to try and not have anything close to a 4th degree. They happen, might be important for your baby to be born, but we're trying to avoid that. So as baby comes out, it stretches this area, and that area, your perineum, may tear a little bit. The big question is it better for you to tear or for them to use scissors and cut a little bit so that it's a little bit more clean cut, easier for them to sew up, and they think easier for you to heal with. So that cut is called an episiotomy. And it is done with surgical scissors, not ones from Scotch from Costco. And while we're here, I want to mention that I am a survivor of I think it was like a 3C tear, so close to a 4th degree tear that was real close to those tissues. So it wasn't fun, but I was able to heal from it. I'm going to give you some tips on healing and how to know what to do about that. But it is something you can come back from, and it is also horrible to think about. I still feel horrible thinking about it, even though I lasted through it. By the way, completely unprepared for having to deal with my bottom that much. I actually have a whole video about how unprepared I was, but I always recommend that you guys get a birth class that really covers postpartum. I have a birth class that does just that, and I'm going to put it down in the description so that you guys can check it out, because I do not want you to be as lost as Hilary was. Please don't be Hilary. Okay, there are times that cut is necessary. So I want to discuss some of those first. And I'm feeling weird. Shouldn't run with scissors. I'm going to put these down. The first one is a shoulder dystocia. So as baby comes out, if baby's a little bit bigger, especially their shoulders, one of them can get caught here at the pelvis. It's called a shoulder dystocia. There's things that we do, pulling your legs back. A nurse is going to try and rotate that shoulder to twist baby to come in a little bit easier. But it can be an issue where the doctor needs to reach up inside and kind of turn baby. And in that instance, they believe it is safer at times to cut an episiotomy rather than to let you tear. So that might be something to think about as well. Now, a lot of shoulder dystocias are resolved from the outside. The nurses are going to jump up, you might have seen this on social media, and push that baby to help them turn to get out of the birth canal so the doctor doesn't have to go up there. And there's no need for an episiotomy. But it can still be a tense situation. It's something we like to try and avoid, but episiotomy could be necessary if you have a shoulder dystocia. Also, if baby is not looking good at the very end, an episiotomy may be the quickest way to get baby out and so that we can help take care of them. Honestly, I think these are pretty rare. I don't see the episiotomy cutting off a lot of birth time, but it can be a thing. And finally, which is the one they talk about most, is when they use forceps or vacuums. Now, I have a whole video with a doctor about forceps or vacuums that I'm going to link to up above and down below. If you guys have more questions about that, look into that. But the studies do show that if you are having to do, it's called an operative delivery when they use forceps or vacuum, that an episiotomy may be more appropriate than allowing you to tear. And in fact, I did look up the studies on that one, and there is a study that supports that there is less longer tearing, meaning you're not going to get to a 3rd or 4th degree if they cut you before they do forceps or a vacuum. By the way, forceps, one of the risks of a forceps is an increased amount of tearing. But the doctor that I had on my podcast did not show that vacuums were an increased risk of tearing, but I think it might be depending on how you're going to use the vacuum. So again, check out that podcast. So much good information about forceps and vacuums on that one. Now, one thing that I didn't see is sometimes patients are starting to tear up towards the urethra instead of tearing down, which, as you can imagine, we got to protect the urethra. Sometimes they will start a cut going down because they want to funnel that pressure away from going up towards the urethra and put it more down towards the anus in hopes that it won't tear that much. Quick reminder, you have 3 holes. There's the urethra where you pee, there's the birth canal, and then there's the anus where the poop comes out. Another time that I definitely have seen is that patients sometimes just get so tired at the end. Baby's right there, and they just don't have the effort to be able to push. And I have seen providers offer patients the opportunity to have an episiotomy to decrease the amount of effort that they're going to have to give right there at the end. Quick reminder that it is a 2-hour average of pushing out your first time baby. And so sometimes your gas tank is just empty there at the end. So a provider offering you, if you want to have an episiotomy, going over the risks and the benefits, I think that that's valid. I actually had a provider who offered me an episiotomy on my second baby, and I was like, oh no, we are going to push this baby out. I'd been frustrated because it had been taking kind of a while to push him out, but it turns out he was a whole pound bigger, which is why it took longer to push him out. But I was kind of frustrated by it. And she goes, well, I can give you an episiotomy if you want to make it faster. And I was like, oh no, we're not going to do that. So, but I think it's valid to ask. And then you get to make the choice if you want it or not. Because one person is going to say, yeah, I'm absolutely done. I want this baby out. I don't care how long I have to heal. And the other person is going to say, absolutely not. I totally want to protect my perineum. Do not cut me. Thank you. 2 different people, totally valid ways of living their lives. Now, back in the day, and I will say even just a few years before I had my first baby, who is now 25 going on 26, they were giving everyone an episiotomy. And actually, when I started in labor and delivery in 2001, I saw a lot of providers that were doing this. In fact, we had one female provider who did it on every single patient. First baby, 5th baby, she cut an episiotomy, which a lot of the older nurses that had been there a long time just started reporting her every single time. And then she ended up moving. So I think she's retired by now, though, or I would save all of you from her. But now they are coming upon a selective episiotomy. So that's basically just an episiotomy when necessary. So instead of doing it every single patient, you're looking for those times when it's really necessary. And of course, I looked at the research, and there is a Cochrane reviews that reviews several studies, and I want to tell you the things that came out of it. I'm going to be looking at my phone to make sure I get this correct for you guys. Selective episiotomy, which again means that they only do it if necessary, reduces severe perineal tearing by 30% versus routine episiotomies. That's great news because that means that it decreased how often it was going to like a larger 3rd, 4th degree tear versus just a 1st or a mild 2nd degree tear. There was no real difference in infection rates between the two. I have heard some doctors say, oh, you're less likely to get an infection if I cut it. Again, not true according to this study. There were less moderate to severe reports of pain at 3 days postpartum, which means those ladies were just in less pain, which is a big win after you have a baby. And I'm here to tell you that with my almost 4th degree tear, the narcotics did not even help because it's something that you're sitting on. So you're putting pressure on it all the time. Again, we're going to talk about how to take care of your bottom, so stay tuned. There were no changes in baby's APGAR scores. Those are the scores that we give the baby after delivery just to kind of tell us how baby is doing. And again, babies all did about the same. It didn't matter if they got an episiotomy or not. And looking about 6 months after birth, there was no difference in reports of pain with intercourse, and there was no increase in reports of urinary incontinence. Again, looking about 6 months out from delivery. Now, they didn't really show like soon after delivery. And so, that might be increased. But of course, we're looking more at the long term of these things rather than the short term. But I would have loved to have known some shorter term information as well. Now, there were a few other things that I just wanted to pull out that I found interesting from this study before we dive into that. So if this is your perineum, so this is the birth canal, and back here is your anus where the poop comes out, it is possible to do a cut that goes more towards the side, towards your thigh. That's called a medial lateral versus a midline, which goes back towards your anus. And the study showed that there wasn't really any difference for those people if it went straight back or towards their thigh. And none of the studies, which a big sigh and a big eye roll, reviewed patients' pain, longer than 3 days out. We're talking, a week out. 6 weeks out? How was their pain after that? And also just their general satisfaction towards birth. None of the studies looked at that. Why are studies not looking at that? That's such an easy question to add on. If you're doing a study about pregnancy, please add that on. It did note that hospitals actually save money when we don't do episiotomies because patients are less likely to stay longer. Again, I don't think it's a reason to not have an episiotomy. I thought it was interesting that they noted that on the study. And I have this whole post with all of the studies linked. I'm going to put that down in the show notes so you guys can check it out and look at the studies for yourselves. So what are the benefits of an episiotomy? Why are we doing them at all? Well, back in the day, they said that just cutting something is easier to sew up. You're more likely to heal rather than something that's jagged that tears. You can imagine that if I ripped a paper, it might be harder to tape it back together exactly perfect versus cutting the paper. That's what they were thinking. However, studies have shown that really both things repair and heal pretty darn well, but episiotomies do decrease your incidence of, and I've got to look at my phone because these are big words, obstetric anal sphincter injuries, called OASI, meaning that it's extending to that area, which we know can cause further problems down the line. And the study that talked about that is talking about when you use forceps or vacuums in a delivery. And again, that study is linked in my article. Now, I was actually just talking to my friend that I'd written this article. We had our first babies at about the same time. And she said, my doctor told me that it was better to, stitch up the cut rather than the tear. But the idea is, if there's any sewers out here or people who used to visit Joann's Fabrics, #crying, I'm sad it's not there. But if you have a piece of fabric and you are, something stretching it, it can stretch a little bit. Let's think of like a knit fabric, like your t-shirt. However, if you put a little cut in that fabric and then you stretch it, you know that tear extends down. In fact, at a lot of those fabric shops, they just put a little cut in it and then they rip it, right? And that is the same thing with an episiotomy. They're showing that people who get that cut, the tear ends up extending more towards that anal sphincter than if you had just allowed it to stretch on its own. And there are actually things that you can do to prevent tearing at delivery. I actually have a whole video about it. I'm not going to review it here, but I'm going to link that video down below and it might show up above as well. This video is getting super long, but I did want to address one thing that I see a lot online, and that is that coached pushing causes more episiotomies than guided, like patient allowing pushing. And I just want to remind you guys that there are two different types of pushes, right? I actually have a lot of videos on pushing that you guys can find on my channel. I'll link them down below. But there's a certain type of pushing where you're trying to just get baby to crowning. And that's where you see the top of the baby's head at the birth canal, even when you're not pushing. That's what I call crowning. So again, I'm going to use this pelvis as though it were your perineum because I don't have a birth canal, a crocheted birth canal hanging around. But as you can imagine, when baby's up here pushing versus when baby's right here and things are really starting to stretch, that is when the tear ends up happening. It's not happening, when we're helping that baby descend to the crowning point. And I would love to live in a world where uncoached pushing would allow people to get their baby to the perineum. But as someone who has helped thousands of patients get their baby to that point on the perineum, I'm here to tell you that a lot of times you need coached pushing, you need closed glottis pushing, which again, I talk about on those posts. And then at the end, you have a great caregiver who really helps you. At the end, you're not like pushing down as hard as you can. You're really giving small pushes to help that baby stretch your perineum and come out with it as intact as possible. That's what a great provider is doing. So I want to give you guys the difference between the two. I see a lot of people online saying, oh, coach pushing increases episiotomies. But we do different coach pushing as the baby is coming out of the perineum than we do when baby is still up high and we're trying to get him down low. Also, there's the whole fact of delayed pushing, which just seems like it's in limbo. That's where we wait until you feel the urge to push. Some studies are showing that it's problematic and that we shouldn't do it. And then I've just seen a new study come out that shows that you should be doing it. So I think it's worth a conversation if you don't feel the urge to push at all with your healthcare team to decide when is the best time for you to push. And again, I have a video all about pushing. So I'm going to let you guys watch those if you have more questions. Okay, so how does this all apply to you? The first thing is to talk with your provider about how often they do episiotomies. This is a great time to see how open they are to communication and truthful, because if they say never, that's not true, right? They could say, I do them really infrequently, or I try and avoid them, but sometimes they are necessary. And that is the gold ticket right answer for me. If they say never, that shouldn't be true, because there are cases where they are necessary, even though that would be, pretty rare, but pretty rare is different than never. And I think it's a great idea to ask your provider, do you use forceps? Do you use vacuums? Most providers are really only trained in one, although some great providers are trained in both. So ask them which they do most often. They may do one or the other or both, but then you just kind of know. As a reminder, forceps, you do have an increased risk of tearing, and so that might be a time where they would think about episiotomy more likely than when they use a vacuum. Which again, all of this is over my pay grade. I'm just trying to explain it to you guys. I think it's important that you guys are aware that a cut may be necessary, and it's something to think about between you and your partner and discuss with your provider about what you want them to do if they find it's necessary. I will say that there are times where it is emergently necessary, and so you need to have enough trust in your provider that they get to make that call. This is your doctor. They could be making life-saving, life-changing decisions for you. So I would hope that you had some trust in them on the big things like that.
I wanted to put something real quick in here about consent. There are times when this is emergently necessary where we really do not have time for an informed consent. They may have the opportunity to say, I'm going to cut you. Is that okay? There may be times where they can't even say that for your and baby's safety. So have these conversations in the office to talk with your provider about what you want and what you want them to do. But I think that's important to mention. Sometimes informed consent's not always an opportunity, but sometimes it is. And they should be at that point giving you the risks, the benefits, and the alternatives, as long as everyone's safe.
And finally, learn how to take care of your bottom after you have your baby. I was completely unprepared. So many birth classes just end like after the baby's out and act like it's sunshine and rainbows. And I'm here to tell you that it's not. So I always recommend a good birth class that goes over postpartum. I'm going to link the one that I recommend down below. But I do have a whole video on how to take care of your bottom. It's honestly a whole new world down there. So I'm going to link that up above and down below. Are you worried about tearing? Tell me down in the comments. Thanks for joining us here on The Pregnancy Nurse, where we get you prepared, not scared, for your upcoming hospital birth.